This is Dr. Baliga here, along with my co-chair, Dr. Charles Hou, who is the head of Department of Planning and Management at the Mackay Memorial Hospital in Taiwan. It gives me great pleasure to introduce you to a terrific panel of world-class and international giants in heart failure. Our first speaker is Dr. Gregg Fonarow. Our second speaker is Dr. Ileana Pina. And our third speaker is Dr. Balakrishnan. I now hand the mic to Dr. Charles Hou for some introductory remarks.
Hi, good morning, everybody. It's a pleasure and honor for the organizing committee to invite us to attend this APSC joint session on the topic of recent update of heart failure. As we all know that the latest trial, landmark pivotal trial, showed that there are very many interesting compounds showed that the heart failure patients can really get benefit from these new clinical trials. And today we have several speakers, both from the United States and from Asia as well, to discuss in depth on these clinical trials to see whether they will play more pivotal roles in upcoming heart failure holistic care. I'm going to give my chair back to Dr. Baliga for him to introduce our first speaker. Dr. Baliga.
Thank you, Dr. Hou. Our
you.
first speaker is Dr. Gregg Fonarow. He's professor of medicine and he's the director of the Division of Cardiology at the UCLA Cardiovascular Center, USA. He needs no introduction. He's a giant in the heart failure and cardiac transplantation field. He's going to speak to us today about the optimal sequencing of guideline-directed medical therapy for HFrEF or heart failure with reduced ejection fraction. On to you, Dr. Fonero.
I'm delighted to be part of this symposium and present on optimal sequencing of guideline-directed medical therapy for heart failure with reduced ejection fraction. Please note my disclosures. As this slide shows, heart failure is common, costly, and by its natural history, deadly. This is a major public health problem resulting in substantial morbidity, mortality, and healthcare expenditures. Now, fortunately, we have a number of evidence-based guideline-directed medical therapies for heart failure, but unfortunately, there are a large number of eligible patients not being treated with one or more of these therapies. And even with what was previously considered conventional therapy, patients remain at substantial risk for disease progression, heart failure hospitalizations, and death. This is data generated in the US, get with the guideline heart failure, about individuals hospitalized with heart failure. And you can see, looking at their median survival compared to those of comparable age in the United States, that for age 65 to 69-year-olds, there is a median loss of life associated with heart failure of over 15 years. And even for those above age 90, 4 years loss of life. So by natural history, heart failure is associated with a marked increase in mortality. This is data generated from the UK, and although there have been some improvements over the last decade in survival, you can see they're relatively modest, and 1, 5, and 10-year survival remains poor despite the availability of therapies established to reduce mortality risks. So there remains a very high residual risk as well as incomplete application of these therapies. Now, if we look for heart failure with reduced ejection fraction, we have a number of therapies that have been studied in placebo or active controlled trials that have been demonstrated actually have such potent efficacy, they can reduce all-cause mortality with large relative and absolute risk reductions, very respectable number needed to treat to save a life. And these therapies also substantially reducing the risk of heart failure hospitalizations and rehospitalizations. But a fundamental question is, are these therapies truly additive to each other in their benefits? Or can we pick our favorite one or two of these therapies and apply those? So what is the effect of adding one guideline-directed medical therapy to another in heart failure with reduced ejection fraction? Is there data to truly support that these therapies are additive to each other? And as I'll now show you, there is. So this is the data establishing ACE inhibitors in heart failure with reduced ejection fraction of prolonging life compared to placebo. So a number of trials demonstrated this. But then as we look at the effect of adding ACE inhibitors as background therapy to now adding beta blockers on top of that, we see in trial after trial truly additive incremental benefits for patient survival and significant reductions on the order of 34 to 35% relative risk reduction in all-cause mortality. Now, with aldosterone antagonists added to these background therapies, the RALS trial originally had low use of beta blocker therapy, did reduce mortality on high background ACE inhibitor ARB therapy. But we see in the more recent Fmhf trial with high background ACE inhibitor or ARB and beta blocker use, there was a significant incremental reduction in all-cause mortality. So again, we're seeing the additive benefits. Now, in the case of sacubitril valsartan, it was compared to the ACE inhibitor enalapril, and this is really then isolating the additive benefits of adding neprilysin inhibition, met its primary endpoint, reduced CV death. But importantly, there's the incremental benefit in all-cause mortality of sacubitril valsartan compared to the ACE inhibitor. So again, additive incremental benefits. And importantly, in these trials, we really see this as a population-wide benefit. Across patients, heart failure with reduced ejection fraction, we could not identify a subgroup of patients where in fact they were better off with the ACE inhibitor, that the addition of neprilysin inhibition in sacubitril valsartan provided benefit that was truly without heterogeneity or significant interaction and across all clinically relevant subgroups. Now, more recently, we have the remarkable data with SGLT2 inhibitors showing the standard background therapy, including ACE inhibitor, ARB, or sacubitril valsartan, beta blocker, and MRA, an incremental benefit. Similar benefits were shown in DAPA-HF and EMPEROR reduced, and when the trials are pulled together, clear reduction in CV death, hospitalization for heart failure, and importantly, an incremental benefit for all-cause mortality. And these benefits were the same whether patients had type 2 diabetes or not. So we have an additional mortality-reducing therapy, and again, no major heterogeneity across clinically relevant subgroups. So this defines that we have a number of therapies for heart failure with reduced ejection fraction that compared by natural history, where the 2-year mortality rate is approximately 35%, that we can reduce mortality markedly. But a key question then becomes of how should we sequence and introduce these therapies? Should we follow the order in which they were discovered and tested in randomized clinical trials? Well, if you take this literally and follow the serial treatment strategy from the historic trials, we would start off with ACE inhibitors and then up-titrate at 2 to 4 week intervals before adding a beta blocker, and then only after having fully up-titrated the beta blocker to maximally tolerated dose would we think about adding the MRA, and then only after that think about switching to sacubitril valsartan, and only then starting the SGLT2 inhibitor. It would take 28 to 56 weeks till guideline-directed medical therapy was fully implemented. Well, do we have that time? What is the timing of guideline-directed medical therapy's clinical benefits? And what we see in study after study, the benefits begin within a few days of initiation. In severe heart failure, initiation of the beta blocker carvedilol within 2 weeks, survival curves had diverged. The risk of worsening heart failure or serious adverse events is much higher delaying the beta blocker than starting it at the time of diagnosis. We see for MRAs, these survival curves diverging within a few weeks and significant clinical benefits within 30 days. We see the remarkable data from Pioneer-HF with de novo or existing heart failure of starting sacubitril valsartan within 24 hours of hospitalization versus the ACE inhibitor enalapril, benefits with the curves diverging within 7 to 14 days, significant benefits by 30 days, and by 8 weeks, this 6% absolute risk reduction in CV death or rehospitalization for heart failure and 42% relative risk reduction. Delaying the initiation of sacubitril/valsartan to start an ACE inhibitor first leaves the patient at significantly higher risk for events. And the timing for SGLT2 inhibitors for their clinical benefits are absolutely remarkable. Within a few days, we are seeing significant reductions in clinical events occurring, improvements in health status, and in the Soloist trial, in-hospital initiation of the SGLT1/2 inhibitor, the curves diverge within days, and by 28 days were highly statistically significant. So we can cut the risk in the first 30 days by more than half by starting an SGLT2 inhibitor. So all of this data really adds for a compelling case of why for hemodynamically stable patients diagnosed with heart failure with reduced ejection fraction, ideally, we would start at the low guideline recommended doses, all 4 of these life-prolonging therapies simultaneously or in rapid sequence over a few days, focus on the up-titration of beta blockers to get to target dose, and then fine-tuning the doses of the other medications. And then by day 21 or 42, we'll be on optimal doses as well tolerated of each of these therapies. By doing this, we can get remarkable benefits, a greater than 75% relative risk reduction in clinical events within that first 30 days. So the focus on comprehensive disease-modifying medical therapy being started quickly is critically important. And this approach has been embraced by the recent ESC guidelines. So what are some of the benefits of simultaneous or rapid initiation of the 4 pillars of guideline-directed medical therapy? They're multifaceted. We can get rapid improvements in health status, rapid improvements in EF such that some patients will not otherwise need an ICD because their EF is now above 35%. Rapid reduction, hospitalizations, rehospitalizations, very rapid reduction mortality. And importantly, by starting these therapies up front, we can improve the use, adherence, persistence, and overcome therapeutic inertia. This slide highlights how when individuals are hospitalized with heart failure with reduced EF, clinical inertia begins in the hospital and continues on an outpatient basis. Patients who are not started in hospital in any one of the guideline-directed medical therapies are unlikely through the next year of outpatient follow-up to be started. And there's very little initiation or up-titration in most outpatient settings. So in hospital initiation of each of the key mortality-reducing guideline-directed medical therapies have all of these benefits, of patients more likely to be treated, better tolerated, better adherence, persistence, they'll feel better to be able to stay home, and more likely to survive. Beyond in-hospital initiation and starting all 4 classes of medication to diagnosis, there are other strategies that can help facilitate guideline-directed medical therapy initiation as shown on this slide, including performance improvement systems, telehealth, digital health tools, and engaging patients in their own active health to ensure that they're prompted around the key survival-enhancing medications. Now, certainly there is a cost for some of these medications that are not available generically, but when we do formal cost-effectiveness analyses, each of them provide high value. But is it worth the time and the effort to get patients on each of these therapies? So to really address this and whether there are truly incremental benefits that are large enough to justify the effort required, we looked at the impact of being on an ACE inhibitor, ARB, and beta blockers baseline therapy versus truly making the effort to be on comprehensive therapy, sacubitril/valsartan, beta blocker, MRA, and SGLT2 inhibitor. You can see the relative risk reductions utilizing this network analysis of trials to look at the incremental benefits are quite substantial. But what does that mean for survival free from all-cause mortality? Well, not compared to just being on nothing in the natural history, but just improving medical therapy can extend median survival for patients by 6.3 years. So that substantial loss of median survival, much of that can be given back by providing truly comprehensive, four-pillar quadruple therapy of SGLT2 inhibitor, MRA, beta blocker, and sacubitril/valsartan. Clearly worth the time and the effort to our patients. Now, do we have evidence that more closely following the guidelines and applying these guideline-directed medical therapies work not just in clinical trials in real world? This is data from Improve-HF, where we demonstrated for every 10% improvement in guideline-directed medical therapy, a 13% lower risk of mortality. And the cumulative benefits here get to a 83% relative risk reduction mortality. So translating our evidence and guidelines into routine clinical practice translates to major benefit. What's interesting, in our clinical trials over the last 20 years, cardiovascular and all-cause mortality has fallen dramatically. However, in the community, when we look, there have been very modest benefits. Why? Because in clinical trials, it is required that standard background therapy be applied before the experimental therapy, whereas in community settings, there aren't necessarily standardized protocols and many patients remain untreated. So the cumulative impact of evidence-based heart failure with reduced ejection fraction medical therapies are profound. We can lower all-cause mortality by close to 75%, absolute risk reduction of 26% in just 2 years, and number needed to treat to save a life is a remarkable 4. Now, not every patient is a candidate for each of these therapies, and even a 9.5% mortality rate is still too high at 2 years. So we need further research. But this clearly illustrates the magnitude of benefit by focusing on quadruple therapy and starting it early and comprehensively in our patients. This shows the population-wide benefit that would occur in the United States with optimal implementation of our existing therapies. We could save an additional 130,000 lives per year. And I imagine countries across the world, we could see similar types of benefits by bridging these treatment gaps and providing optimal therapy. So to summarize the approach to sequencing heart failure with reduced ejection fraction medications, the benefits of these therapies are truly additive and incremental. No substantial overlap has been demonstrated for the 4 key evidence-based therapies: sacubitril/valsartan, beta blocker, MRA, and SGLT2 inhibitors. The optimal approach is to utilize each of these medications demonstrated to reduce all-cause mortality in combination, so long as not contraindicated or not tolerated, and start each without delay. A serial or selective go-slow approach leads to delays, as well as heart failure hospitalizations and deaths that could have been prevented with earlier, more expeditious, more rapid use of guideline-directed medical therapy. And I hope I've shown you well that sacubitril/valsartan, beta blocker, MRA, and SGLT2 inhibitors each provide high economic, and most importantly, high clinical value to our patients. Thank you so much for your attention.
Thank you, Dr. Fonero, for this terrific talk. It's thought-provoking. And just like we have door to needle time for interventional cardiologists, your talk tells us that there must be a diagnosis to GDMT start time, which we will reserve for the Q&A. Our next speaker is Dr. Ileana Pina, who is professor of medicine at Central Michigan University. She is also a giant in the field of heart failure, and she's going to talk on current updates in heart failure management.
Hello, I'm Ileana Pina. I'm clinical professor of medicine at Central Michigan University and adjunct professor of Epi and Biostats at Case Western. We're going to talk today about the complex landscape of heart failure and how many more therapies we now have available, which is a good thing, but it gets a bit more confusing when you have to choose which one, as you've heard from Dr. Fonero. So the landscape keeps getting more complex. The patients are more complicated, more comorbidities, hospitalizations are still up, even though during the COVID time, heart failure hospitalizations actually went down in the United States and in some European countries, such as the UK. But nonetheless, the patients are becoming more challenging as costs continue to rise. And this is not a syndrome that we take care of just one-on-one. This really does require a team effort. And how have we been targeting this syndrome? Well, we've been focusing a lot on the sympathetic nervous system with beta blockers, the renin-angiotensin-aldosterone system with ACE inhibitors, ARBs, with MRAs or mineralocorticoid receptor antagonists. We've tried the vasopressin, endothelin. We've examined all of these, and a lot of these will lead to the sodium and water retention that we use diuretics for. And then finally, loss of contractility is very often underlying a lot of the issues with the HFrEF population. Where have our guidelines been taking us? Well, our guidelines are telling us that you really need to use the RASI blockade, and the RASI blockade is made up of ACE inhibitor, ARBs for the patients who can't take an ACE, MRAs, and more recently, the ARNIs made their presence known, and now the ARNIs are becoming more favored in consensus documents and in up-and-coming guidelines. However, there are differences between the US and the European guidelines, and we'll see that in a moment. The expert consensus decision panel met for the American College of Cardiology and added now the SGLT2s, which I'm going to be talking about briefly, and brought up the ARNI as a preferred early RASI inhibitor and using it as first line of defense, not just after you have the patient already on an ACE inhibitor. But remember, this is a consensus decision panel. This is not a guideline. The guidelines for the American Heart will be coming out probably early 2022. The Europeans, though, have published their guidelines, and the Europeans really do a beautiful job of their charts and their pathways, making it very easy for clinicians to take a look at the recommendations. They have not elevated ARNI any higher. They have put the ARNI right next to the ACE inhibitor, kept the beta blockers, the MRAs, but now are introducing the SGLT2s, which I'm fairly certain that the US guidelines will also do this. And they include the loop diuretic. Remember, it's for fluid retention. That's what the loop diuretics do. And they still support the ICD for patients who remain with an EF of less than 35, and for those patients who are qualified candidates, CRT, whether CRTD or CRTP. Paradigm came in with sacubitril valsartan, showing us this new drug. This has now been several years ago. The use is still quite low, and it was a comparison of these two doses of sacubitril valsartan to 10 milligrams twice a day of enalapril. And the patients were in their 60s, about 20% women, which is actually pretty much par for the course in these trials, mostly ischemics, ejection fractions in the in the 20s. So this is really a good HFrEF population, class 2 and 3, but the NT-proterminal BNP was elevated. So this is a group that is symptomatic, and a little over a third of them were diabetic. Here we start to see again the many comorbidities of this complex group of patients. More recently, the Paradise-MI trial that was presented at the ACC and compared the drug again, this time to ramipril in a post-MI group that had ejection fractions of less than 40, it did not meet its primary endpoint. Therefore, all the other endpoints become exploratory, and they seem to always favor the sacubitril valsartan group. But nonetheless, this is an important study presented at the ACC. The CHAMP registry really opened our eyes, and a little bit depressing because we're not doing such a good job. When we see the patients who are at stable target doses, for example, of an ACE inhibitor, it's like 8.5% of this 2,500 patients. If we look at the ARNI, it's even smaller because the ARNI used here was very, very small. For beta blocker, 18%, a drug that we've had for so long that has been so beneficial, including reverse remodeling, still not doing well. And the MRA at 22%, a bit better than what I would have expected, because in the US, the ARNI, the use of MRAs is really not as great as in Europe. We also have been learning through these past few years that removing the RASI inhibition is not a good idea. And here is a study that looked at withdrawal of the ACE or ARB, and it shows very clearly in the central graph that those that discontinued or were never started were almost identical in a higher mortality than those who had started the drugs and continued them. The same thing for the readmissions and for the combined endpoint. So we have a lot of reasons, sometimes excuses, for stopping these drugs. Hypotension is whatever really the patient is symptomatic with. Azotemia, often an effect of the actual drug, not a damage to the kidney. As a matter of fact, these drugs are protective of the kidney. And it doesn't matter if you look at ACE or ARB, the reasons for stopping them are very similar, almost exactly the same. So now let's turn to the new targets that we have now on the docket. We have a new vasodilator in the soluble guanylate cyclase modulator. We have the ARNI, which we already talked about. We have new binders of actin and myosin, and up and coming non-steroidal MRAs, which I will not be discussing today. So now that we have these choices, how are we going to make the decision? Well, let's look at the data. So the selective cardiac myosin activator, omecamtiv mecarbil, literally increases the binding of actin and myosin, sort of as a tightening of the bind. The interesting things about this drug is that it does increase the duration of systole, but always a really microscopic amount. However, it does decrease diastole some and doesn't seem to have a negative effect there. Stroke volume goes up. There is no increase in myocyte calcium, which is what we don't like in the inotropes, no changes in DPDT, and very importantly, no changes in myocardial oxygen consumption. The company has really studied the drug well through different patient groups. The latest trial was Galactic, where the primary outcome was met with a very modest 8% reduction, which did meet statistical significance, absolutely no change in mortality. Notice that this group had a mortality at a year of roughly, looks like 10 to 12%. Not a very sick population. However, we always look at subgroups because subgroups sometimes lead us to look at specifics of why a drug isn't working in one group and why it's working in another. And in this case, if you look at the median left ventricular ejection fraction, which was 28%, the patients that were low but below that median seemed to have a benefit. And the patients who were above that, that benefit seemed to be diminished. And now the confidence intervals, although are still fairly narrow, the point estimate has moved over on the other side of 1. Where this drug will fit in, it is not yet approved by the FDA. Let's now look at the new vasodilator. So this is a very, very interesting drug. It's called Varisagua. And we have had another similar drug in Riociguat. This increases the soluble guanylate cyclase activity to improve myocardial and vascular function. So this really is going back to a very old theory of the nitric oxide, so that with heart failure, oxidative stress and endothelial dysfunction make a decrease in the ability to grab that nitric oxide and have it work as a vasodilator, and also decrease activity of the guanylate cyclase enzyme. What this drug does is it increases the activity of the enzyme, and therefore it improves the production of cyclic GMP. Let's remember that cyclic GMP is in fact the receptor that works with in progressive myocardial stiffening reduction, thickening, remodeling. So it's one of those remodeling receptors, and fibrosis, and in the vasculature. Let's not forget reducing arterial vasoconstriction and reducing vascular stiffness. So it would make sense that if we added this drug to patients who have pretty severe or significant heart failure, that we should be able to see a benefit. So in fact, the Victoria trial actually did that. Randomized patients who had HFrEF and who were on baseline medical therapy, reasonable medical therapy, and the medical therapy, I think more publications will be coming out, and the patients were randomized to the Varisagua and to the placebo. The good thing is no drops in blood pressure, no worsening of renal function. So in that sense, the safety profile is quite good, and it met its endpoint. Again, modest 10% reduction. And where was that reduction? The reduction was in the heart failure hospitalizations in the reduction of the first heart failure hospitalization at 29% versus 25.9% with Varisagua. So the primary endpoint was in fact positive. So let's look at this. So the death, absolutely no change. So very similar to what we saw with omecamtiv mecarbil, there's no mortality benefit, but there is definitely a statistically significant reduction in the first heart failure hospitalization. Also interesting in this subgroup analysis is that the patients who had the highest NT-proBNP, which in this case was greater than 5,300, seem to not benefit from the drug. And I know these groups are being looked at now very, very carefully. What is interesting about this trial is that it had one of the largest event rates that we have seen recently in events. So these patients were having a lot of events. They were having them early. Who were they? They had been primarily hospitalized, and they had a high NT-proBNP. So these are the risk factors that you should be looking in your patients. And now let me turn my attention to the SGLT2 inhibitors, drugs that have really surprised us because initially tested in diabetics, and all of a sudden, the hospitalizations for heart failure were diminishing and the curves were splitting up very early. And it's been this incredible surprise of what these drugs can do. This is the original EMPA-REG outcome showing this very highly significant reduction in heart failure hospitalizations. And now as we've started to learn much more about the drugs, not only the diabetics, but the non-diabetics seem to benefit the same. And not just patients who haven't had heart failure, but those that have had heart failure also benefit very significantly. You can see that all the point estimates are on the side of favoring the treatment. And these are like 3 different SGLT2, canagliflozin, dapagliflozin, and empagliflozin. And if we look at it this way, in a meta-analysis, the point estimate of all these 3, which are different drugs, still fall in a very significant fashion on the side of the drug. The DAPA-HF was presented a couple of years ago at the European Society of Cardiology meetings, and it made a very important point of looking at this primary composite outcome reduction of like 26%, which is quite a significant number. And again, the hospitalizations or an urgent visit with a 30% reduction, heart failure hospitalizations, 30% reduction, and for the first time, a reduction in mortality of about 18%. That has not always been reproduced in some of the other trials. And these curves, as we've seen before, split apart very, very early. And for the mortality hazard ratio, we see them splitting within the end, toward the end of the first year after randomization. The other very fascinating thing about these drugs is that they seem to be protective of the kidney. So if we look at this particular trial that looked at the kidney specifically, we know that the creatinines actually go up when you start the drug because there's a sudden drop in GFR, but it comes back up again. And then at the end of the day, there seems to be a preservation of renal function, in this case with empagliflozin compared to placebo. And to me, it sort of brought to my mind that patients start losing their renal function as time goes on. We see small ticks here and there of their creatinines, but they're actually losing GFR as time goes on with their disease. The story is unfolding with these drugs. We don't have one definitive mechanism of action, but we're finding that there's so many things that these drugs can do. Keep your eyes open for the literature on this. And then our real unmet need has been HFpEF, heart failure with preserved ejection fraction, where it's defined differently by different trials. But it means that the ventricle cannot fill at a normal pressure. And the pressures go up very rapidly, reflected in the ventricle and in the left atrium. This is the most rapidly growing type of heart failure, very common in elderly, primarily women. It makes up about 40, maybe to 50% of the heart failure hospitalizations in adults. Patients may have both systolic and diastolic. And these definitions, watch the literature, are now changing. Rob Mentz wrote this, and I like this slide because it talks about all the comorbidities that these patients have. Maybe the heart is an innocent bystander with these comorbidities like anemia, COPD, diabetes, renal dysfunction. Don't forget sleep apnea, which can also lead to high PA pressures, and obesity, which always seems to be coming up time and time again as a risk factor. So what have we done with the drugs? Well, the Paragon trial tried now to use this sacubitril/valsartan combination, but compared it to valsartan because they felt that there was some data from candesartan and charm, and it would not have been ethical to make this totally placebo. And if you look at the trial, the p-value is sort of hovering over the 0.05. This drug, however, has now been approved in the United States for these ejection fractions. And notice again, the heterogeneity of the population. When you get to somewhere around 57% ejection fraction, the drug seems not to do as well, and the point estimates start to move over to the other side. But maybe we're defining HFrEF incorrectly, and maybe our cutoff for HFpEF should be up there at 55, 60, or perhaps even higher. More recently, in the European meetings this year, empagliflozin looked at the HFpEF population, published in the New England Journal, and the trial was extremely positive with a p-value of 0.001, and this is the composite endpoint of cardiovascular death or hospitalization for heart failure. And here we can see again, these hospitalization curves have split very, very quickly. This drug has now been given a breakthrough for review at the FDA in the section concerning drugs. So at least now we have two drugs that are giving us some hope in this population. So what are we dealing with? So we're dealing with this list of drugs that we now have. We're putting the SGLT2 inhibitors in here. We've had hydralazine and nitrates. Where will Varisagua fall? Where will Omcaptive fall? And let's not forget other things like controlling blood pressure and looking for iron deficiency in management of arrhythmias and management of valvular disease. Management of depression. 35% of heart failure patients are clinically depressed, and many of them we know have concomitant kidney disease. So this is why I said at the beginning that the whole landscape is getting more and more complex. And what we should be practicing really is precision medicine, which means let's personalize the approach to improving health and treating the disease, approaching the treatment based on the patient, looking at their family history, their comorbidities. What is their environment? Where do they live? Do they have access to care? Can they afford their drugs? Rather than doing this as cookbook medicine and engaging not only the patient, but also their partners in care, whoever their additional friends, family members are that are involved in their care. We need to be able to rely on electronic health records, although that has not always been possible. And in the COVID era, we learned about mobile technologies that we needed to use. We need better tools for analyzing these big data sets. So what does the future hold? Well, now with HFrEF, we're adding the SGLT2. We've had an aha moment for renal physiology. For HFpEF, we're looking now at new strategies. Maybe we need to phenotype these patients into different groups. Now that we have empagliflozin is positive, the dapagliflozin HFpEF trial will probably be reported sometime at the end of 2021. What are the mechanisms of kidney protection? Why is this important? And then we're still left with the same where we've been for acute heart failure. Really, it's a blip on this long patient journey. So we're in a new area of discovery. We have new targets. We have new agents that have no mortality reduction. We have new mechanisms looking at things from a different perspective. And even failed trials teach us a lot. There's something to be learned even from those failed trials. We need to continue to refine the populations that we study. And once again, that transition from acute to chronic, that transition of care, we're not doing well, and it still leaves us with a lot of work to do. I want to thank you for your attention to me today. I appreciate it.
Thank you, Dr. Pina, for your excellent presentation. Now I'm going to move on to our next speaker, Professor Iswaree. Professor Iswaree is currently the associate consultant with the Department of Cardiology at the National Heart Center of Singapore and associate consultant at the Department of Cardiology and National Heart Center in Singapore. Today, he's going to share with us the topic would be comorbidities in heart failure. Dr. Iswaree, please.
Thank you very much, Dr. Hou. My name is Iswaree and I'm a cardiologist with the National Heart Center, Singapore. Thank you very much for having me at this session with such great minds and pioneers in the field. Today, I'll be talking about heart failure and non-cardiovascular comorbidities in heart failure. I've got no conflicts of interest for the purpose of this study. So as you guys would probably already know, heart failure is a very prevalent condition. About 4.5% of Singaporeans live with heart failure compared to the 1 to 2% in the United States and Europe. Older patients are more likely to develop heart failure. So with people living longer and better heart failure therapy, the prevalence of heart failure is estimated to increase by 46% in 2030. And this is just in the US alone. Having said that, about 30 to 50% of patients with heart failure actually have more than 2 comorbidities. Comorbidities in heart failure can be due to either cardiovascular causes, such as AF, valvular heart disease, or IHD, or it can be due to non-cardiovascular causes, such as diabetes, anemia, or COPD. Whatever it is, the presence of comorbidities in heart failure negatively impacts prognosis, as shown in the table on the right upper corner over here. Though most deaths in heart failure are due to cardiovascular comorbidities, non-cardiovascular comorbidities are responsible for most hospitalizations, as demonstrated in the table in the right lower corner here. In a study by Ben Derson, patients with 5 or more comorbidities accounted for about 81% of hospitalization days amongst heart failure patients and had a longer duration of heart failure hospitalization. Fortunately, addressing these comorbidities has been shown to reduce heart failure hospitalization as well as improve the quality of life. Data from the Asian Heart Failure Registry, which is a prospective cohort study involving more than 6,000 patients from 11 Asian countries, reviewed the impact of multimorbidity, i.e. more than 2 comorbidities in heart failure in terms of all-cause mortality and heart failure hospitalization. This study subsequently pigeonholed them into 5 different phenotypes. The lean phenotype, which is the one in the red colored box at the far end, was more commonly seen in Singapore and Malaysia and was associated with worse outcomes and quality of life. This group consisted of patients with the highest prevalence of comorbidities, such as hypertension, CKD, and diabetes, but with a lower prevalence of obesity. They were also more likely to be patients with HFpEF, in contrast to the young phenotype, which is the box in the middle here, in yellow, where most patients had heart failure with reduced ejection fraction. Patients in the young phenotype group were more likely to have non-ischemic cardiomyopathy and had the best outcomes with the lowest rates of mortality and heart failure admissions. So what this study tells us is that in the Asian cohort, beyond LVEF as a metric for heart failure outcomes, a clinical syndrome of heart failure with increased comorbidities is associated with worse outcomes in terms of increased all-cause mortality, heart failure hospitalization, and reduced quality of life. So heart failure comorbidities need to be addressed with tailored therapy for each specific phenotype to mitigate negative outcomes. Non-cardiovascular comorbidities are independent prognostic factors in heart failure, and often there's a significant overlap and a shared pathophysiological link between these conditions. The comorbidities that have the most association with heart failure outcomes are iron deficiency and anemia, diabetes, CKD, and COPD. And these are the things that I would discuss further in today's discussion. First up is iron deficiency in heart failure. Iron deficiency is an important comorbidity in heart failure because it is associated with reduced exercise capacity, decreased quality of life, and increased mortality independent of anemia. In the general population, the prevalence of anemia is low at about 10%. In the heart failure population, the prevalence is as high as 50% in hospitalized patients. This parallels the increase in iron deficiency in heart failure, where about 80% of patients admitted for heart failure are iron deficient. So let's briefly review the pathophysiology of iron deficiency in heart failure. Number one, iron is an important cofactor for energy production in skeletal and cardiac muscles. In heart failure, a state of chronic inflammation ensues, similar to other inflammatory conditions like inflammatory bowel disease, CKD, or active infection. Let's take an acute infection, for example. What happens in the setting of inflammation is that the body tries to minimize iron intake from the gut and intracellular body source because bacteria needs iron for reproduction. So the body tries to deprive the bacteria of iron. This is also the reason why we don't administer IV iron during an active infection. Independent of the cause of inflammation, be it due to an infective or a non-infective cause, the body reacts the same way. Therefore, in states of chronic inflammation, like in heart failure, patients develop what we call functional iron deficiency anemia, where there's an imbalance between iron demand and serum iron availability. And this can happen despite adequate iron stores in the body. Our iron stores are actually tucked away in the macrophages and hepatocytes and cannot be effectively mobilized during states of inflammation due to upregulation of a protein called hepcidin, which is the main regulator of iron intake and release. Increased hepcidin production causes degradation of ferroportin, which is a transmembrane iron exporter needed for the absorption of iron from the gut, as well as release from the macrophages and hepatocytes. As a result, functional iron deficiency occurs, and there's less iron available for energy production in skeletal and cardiac muscle, which is partly why patients with heart failure feel more fatigued and have reduced effort tolerance. On the other hand, absolute iron deficiency is a lack of iron source in the body. So the exact opposite happens. Hepcidin production is suppressed to allow upregulation of ferroportin to increase enteral absorption of iron and cellular mobilization. These two forms of iron deficiency are not exclusive and can coexist in heart failure. An understanding of the pathophysiology of iron deficiency has taught us what works and what doesn't work in heart failure. Oral iron is ineffective in patients who are acutely or chronically unwell because hepcidin is an acute phase reactant which blocks enteral uptake of iron and its use inside the body. Furthermore, in decompensated heart failure, the already poor enteral absorption of oral iron is made worse due to gut edema, poor appetite, and gastric side effects of oral iron therapy. In contrast to oral iron, IV iron bypasses this need for oral absorption, making it an attractive therapeutic option in heart failure. Trials looking at anemia and heart failure started in the 1990s, and we have come a long way since then. In the early 2000s, the FAIR-HF, CONFIRM-HF, as well as EFFECT-HF studies have shown that IV iron in heart failure improves NYHA class, 6-minute walk test distance, and VO2 max. The AFFIRM-HF trial just published last year further reinforced the benefits of IV iron in heart failure. The AFFIRM-HF trial randomized more than 1,000 patients admitted for heart failure with an EF of less than 50% and iron deficiency to IV pharyngeal versus placebo. The primary endpoint was the total heart failure hospitalization and cardiovascular death within 62 weeks. Baseline medical therapy was good in most of the patients, with most of the patients in the trial only requiring 1 to 2 doses of IV pharyngeal. This trial very clearly demonstrated that IV iron in patients admitted for acute heart failure was associated with the 26% reduction in heart failure hospitalization. Although the primary outcome narrowly missed statistical significance, in the pre-COVID sensitivity analysis, the combined endpoint of heart failure hospitalization and CV death was met. This upgraded IV iron as a Class 2A recommendation in the latest ESC guidelines. Next is diabetes and CKD in heart failure. I will discuss these comorbidities collectively as they are shared risk factors in heart failure. Heart failure is the most common complication of diabetes, followed by atherosclerosis and CKD, and affects up to 40% of diabetics. And diabetes occurs in about 25% of patients with heart failure. Diabetes, on the other hand, is also the most frequent cause of kidney disease, with more than half of these cases requiring renal replacement therapy. The principal cause of death among patients with diabetes and CKD is cardiovascular disease. And there's a tri-directional relationship between heart failure, diabetes, and CKD, in which the presence of one condition increases the risk of developing the other. Overall, patients with heart failure, diabetes, or CKD are at a 2 times higher risk of adverse cardiovascular events and renal outcomes compared to the non-diabetic heart failure cohort. And specifically amongst the Asian population, the Asian Heart Failure Registry has shown that compared to the metabolic diabetics, i.e. the patients with a higher preponderance of obesity and diabetes, the lean diabetics did a lot worse with increased mortality and heart failure admissions. Unfortunately, though diabetes and CKD are major risk factors for heart failure, diabetes was not exclusively studied in heart failure trials, and patients with advanced CKD were excluded from heart failure trials. The chart on the right here shows that in the early heart failure trials, such as the SOLVE and the CHARM trials, only 20 to 30% of subjects had diabetes. However, over the years, in the more recent heart failure trials like Victoria and Emperor Reduced, there has been a greater proportion of patients with diabetes, which is more representative of real-world data where there's a coexistence of these conditions. Other than atherosclerosis, there is a common pathway. Other than atherosclerosis as a common pathway due to diabetes, the exact mechanism as to how glucotoxicity and CKD causes heart failure is complex and not well understood. A few commonly postulated mechanisms include abnormal cardiac metabolism, upregulation of neurohormonal pathways, as well as myocardial fibrosis, and existing heart failure therapies such as ACE, ARNI, SGLT2, and MRAs have been postulated to exert their positive effects by action on these pathways. I apologize, a bit of this is an overlap with Dr. Pina's presentation, but when it comes to diabetes, CKD, and heart failure, SGLT2 inhibition is the buzzword because it is the only diabetic drug that has shown consistent benefits in heart failure and renal outcomes. So in the next few slides, I will focus on SGLT2 inhibitors in specific to heart failure and CKD. The three major cardiovascular outcome trials, EMPERATURE, CANVAS, and DECLARE TIMI-58, which included diabetic patients, were safety trials that serendipitously demonstrated the consistent and robust effect of SGLT2 inhibition in heart failure reduction. Only a small proportion of patients with heart failure were included in these trials, and they were not well characterized. Nevertheless, these studies provided the first evidence that the use of SGLT2 inhibitors reduced the risk of heart failure as preventative therapy in diabetic patients without a prior history of heart failure. The impressive and unexpected findings of these trials then resulted in two further landmark trials in HFrEF and SGLT2 inhibitors, the DAPA-HF and Emperor Reduced, and the recently published Emperor Preserve trial included patients with the LVEF of more than 40%. These trials randomized patients to SGLT2 inhibitors versus placebo on a background of good medical therapy and included about 40 to 50% of patients with diabetes, which is a fair representation of what we see in clinical practice. This is a summary of the endpoints of the DAPA-HF and Emperor Reduced trials from the Lancet meta-analysis I had shown on the previous slide. At a glance, you can see that all the pre-specified endpoints lie to the left of the line of null effect. Just to highlight a few points with reference to heart failure and renal outcomes. Based on this meta-analysis, the composite of cardiovascular death and heart failure hospitalization was reduced by 26% in the SGLT2 group. And this was primarily driven by a reduction in heart failure reduction, with only a modest reduction in CV death. Though the reduction in CV death was modest, it was still significant. And over here, point E demonstrates that the risk of patients having progression of renal disease was also significantly reduced by 38% with SGLT2 inhibition. These findings of reduction in heart failure and renal events parallel the findings of the previously discussed CVOT trials. The pooled treatment effect and the combined risk of cardiovascular death or hospitalization for heart failure was consistent across most subgroups, including those with or without diabetes and regardless of eGFR. Similar to the subgroup analysis of the HFrEF trials, the benefits of SGLT2 inhibitors in the cardiovascular outcomes in the Emperor Preserve trial was also seen in both diabetics and non-diabetics and was not affected by the eGFR. Of note, all the patients in the EF subgroups in the Emperor Preserve showed a reduction in primary endpoint. However, the patients with the LVEF of less of 40 to 50%, the mid-range group, appear to have the greatest benefit. Again, previously discussed by Dr. Pina, the early separation of the Kaplan-Meier curves showed that the heart failure benefits of SGLT2 inhibition were attained as early as 1 to 2 weeks and peaked at about 4 weeks into treatment and was maintained in the long run in all three heart failure trials, including SGLT2 inhibitors. So putting all these data together from these three RCTs, we have evidence that SGLT2 inhibitors confer early and sustained reduction in heart failure hospitalizations, regardless of diabetic status or LVEF in a patient with a clinical syndrome of heart failure. In another SGLT2 meta-analysis published in the Lancet in 2019, it was shown that there was a greater reduction in heart failure hospitalization with SGLT2 inhibition in patients with worse baseline renal function. This could again be partly due to the fact that patients with low eGFR are at highest risk of heart failure events and therefore benefited the most. This slide shows the temporal progression of eGFR trends with the initiation of SGLT2 inhibitors and its renal protective effect. All three trials show a similar trend. There's an initial decline in eGFR by 2 to 6 mils within 2 to 3 weeks of initiating SGLT2 inhibitors. The eGFR then quickly recovers and remains largely stable in the follow-up period. At about 1 to 1.5 years, this line crosses over, while the control group continues to see a constant gradual decline in eGFR. In the DAPA, CKD, and Credence trial, in addition to greater preservation of eGFR, major renal outcomes were also reduced. Similar to ACE and ARV, the acute transient drop in eGFR is due to a reduction in renal hyperfiltration due to afferent arteriolar vasoconstriction. And therefore, we should not be reactive to these transient drops in eGFR and stop SGLT2 inhibitors, but instead should continue to monitor eGFR as the renal benefits of SGLT2 inhibition is actually accrued in the long run and in the long term. With regard to not starting SGLT2 inhibitors in patients with lower eGFR, this is not entirely a safety concern, but rather an issue with reduced glycemic efficacy of SGLT2 inhibitors in patients with lower eGFR. The CVD REAL-2 study is a large international study of more than 400,000 patients with type 2 diabetes from the Asia-Pacific region, represented by Singapore, South Korea, and Japan, the Middle East, and North America. In this trial, only 26% of patients had established atherosclerotic cardiovascular disease, suggesting that this is a low-risk population. Nevertheless, this study looked at a broad range of cardiovascular outcomes, as shown in the table on the right over here, in patients initiated on SGLT2 inhibitors versus other glucose-lowering drugs, including injectables like GLP-1 receptor agonists and insulin. The main finding of the study was an unequivocal cardiovascular benefit of SGLT2 inhibitors over other glucose-lowering therapy. All the cardiovascular benefits, including reduction in heart failure hospitalization, were consistent across all countries, despite differences in the type of SGLT2 inhibitor used, suggesting a class effect. Based on data so far, the extremely consistent and impressive finding is that SGLT2 inhibition confers heart failure, cardiovascular, and renal benefits in both diabetics and non-diabetics. And it is based on that the latest ADA guidelines in 2021 and the ESC guidelines just recently published strongly recommend the addition of SGLT2 inhibitors in patients with diabetes. And this is not because of the A1C lowering effect, which is a meager 0.5 to 0.8%, but rather because of its pleiotropic cardiorenal benefits. And of course, in patients with HFrEF, regardless of the diabetic status, DAPA or EMPA should be used to improve heart failure outcomes. Though the heart failure benefit of SGLT2 inhibition is beyond its glycemic effect, we cannot completely ignore A1C as a useful clinical metric in assessing cardiovascular outcomes and titrating diabetic therapy. Strict A1C control has shown benefits in reducing microvascular complications rather than macrovascular complications. But we also know that diabetic patients whose A1C levels are more than 8% are at an increased risk of cardiovascular and heart failure events. So the use of other agents such as metformin, DPP4 inhibitors, except saxagliptin, and GLP-1 receptor agonists should be considered for better glycemic control and are safe in heart failure patients, although they do not have specific heart failure benefits. And finally, I will briefly discuss about COPD in heart failure. COPD is a very frequent amongst patients with heart failure, with a prevalence ranging between 20 to 30%. And tobacco is a well-known risk factor for both COPD and cardiovascular disease. But in clinical practice, I find that sometimes patients are very shocked to find out that they have heart disease, even though they are chain smokers. For some reason, they think smoking is associated with cancer, and diabetes, blood pressure, and cholesterol are associated with heart attack and heart failure. And I can't help but to think if this is partly due to infective messaging. If you look at the health warning pictures on cigarette packs in Singapore, and maybe perhaps everywhere else in the world, they include very gory pictures of tumors to depict that smoking causes cancer. But when it comes to heart disease, it is a picture of a person undergoing what looks like a CABG. And I'm not entirely sure if the non-medical smoker would know what it means. maybe a more graphic picture may convey the point that smoking also causes heart disease. Anyway, it is always important to remind your patients during clinic visits that smoking just doesn't cause cancer, but it also causes heart attacks and heart failure. Again, COPD may be missed in patients with heart failure because dyspnea is erroneously attributed to heart failure and vice versa. Both these conditions share adverse health effects such as weight loss and skeletal muscle dysfunction, and it can be challenging to differentiate the cause of symptoms, especially in advanced cases. And finally, a quick word on COPD and beta blockers. So beta blockers are the cornerstone of therapy in heart failure and reduce heart failure, hospitalization, and mortality. The beta-1 receptors, the benefit of beta blockers in heart failure is seen due to its action on beta-1 receptors in the heart, thereby resulting in negative chronotropy, and its action on the beta-1 receptors in the kidneys, where it actually causes a decrease in renin secretion. Concerns about beta blockers in COPD arose mainly from early anecdotal evidence and case studies citing acute bronchospasm in patients where only non-cardioselective beta blockers such as propranolol were available, and these triggered severe bronchospasm in patients with asthma, especially at high doses, and somehow this got extrapolated to COPD as well. Recent evidence, however, shows that the newer cardioselective beta blockers are safe and are beneficial in COPD and actually reduce exacerbations by augmenting bronchodilator response to beta agonists. Based on the cumulative evidence, the GINA and GOAL guidelines concluded that chronic cardiovascular beta blocker therapy should not be routinely withheld from patients with COPD because the benefits far outweigh the risks. And just finally, onto my last slide, I just want to part with two very simple take-home points. Number one, the comprehensive management of patients with heart failure should include the management of non-cardiovascular comorbidities, because it has been shown again and again that adequate control of these comorbidities have a positive impact on survival, and more importantly, a tangible improvement in the quality of life of heart failure patients. And number two, wherever possible, maximize complementary drug therapy and rationalize therapeutic regime in heart failure to optimize cardiovascular outcomes. Just to share a few examples, for example, stop oral iron, which has no benefit in heart failure. Instead, screen for iron deficiency and give IV iron if someone is suitable. Don't hesitate to re-challenge beta blockers in patients with well-controlled COPD and heart failure, because the non-dihydroprotein calcium channel blockers, which are often used as alternatives, have limited benefits, and beta blockers have well-established cardiovascular benefits. And always include an SGLT2 inhibitors in patients who have diabetes or diabetic kidney disease where possible. So with every patient you manage, make it a point to review their medication list with an intent to optimize, review their medication list with intent to optimize outcomes and minimize polypharmacy, which is an entire comorbid in itself. With that, I thank you all very much for your time, and we'd be happy to take any Q&A questions during the Q&A. Thank you.
Thank you for that outstanding talk, Dr. Balakrishnan. I think we'll, in the interest of time, we'll proceed straight to the Q&A. Are there any questions from the participants?
Yeah, there's a question from the audience. Said that is there a role to discontinue guideline-directed medical therapy medications if LV ejection fraction recovers back to normal? So any comments from the speaker?
Sure, I'll start. And aren't we so fortunate that we have patients that respond so well to medical therapy that they completely normalize their left ventricular ejection fraction? Those patients have a much better prognosis and a very bright future. However, we do have trials like TREAD-HF that randomize such patients to discontinuation of GDMT. Trials stopped early due to a proportion of patients having a recurrence where their EF drops. So current guideline recommendations are, in the absence of contraindications or intolerance, to continue therapy indefinitely. There may be some rare exceptions where there's, complete recovery after a transient reversible illness, but for the most part, we should be continuing therapy.
Okay.
I have a question for the panelists. The nephrologists feel that, for diabetes, they've been using ACE inhibitors as foundation, diabetic nephropathy. And they're arguing that maybe SGLT2 inhibitors will replace ACE inhibitors. And I know this is hand waving, but I was wondering whether SGLT2 maybe we'll be able to reduce the number of medications to give to our heart failure patients and bring it down to one. I know we don't have data, but what are your thoughts, Dr. Fonero?
I'll be really brief. I think, the SGLT2 inhibitor studies were on a background of RAS inhibition. The beauty is, for chronic kidney disease, we need those RAS inhibitors, MRAs. Now we have the phenomenal data with finerenone, and then, the SGLT2 inhibitors. So it's really combination of essential medications. Iswaree did a great job highlighting the comorbid conditions, but we're getting 2 and 3 FERs with some of these medications, and the ones we need to get rid of are the ones like non-steroidal anti-inflammatory agents that worsen heart failure and kidney disease, and those that really don't provide meaningful improvement in the disease state.
I think that the mechanism of SGLT2 versus RAS blockade on chronic kidney disease is a little bit different, because one is acting on the afferent side of a vessel, the other one is on the efferent side of the vessel. So these two are actually complementary with each other. Yeah, that's my personal comments. I have a question for Professor Fonero. In your talk, you mentioned that instead of using sequential or serial add-on of these 4 major pillars of heart failure medication, you will suggest simultaneous usage of these 4 drugs, and starting from low dose. I mean, but one of the drawbacks of ARNI is actually it's a pretty potent hypotensive agents, especially in Asian population. So what would you recommend for the starting dose of ARNI if you want to use the other 3 combined combination therapy with ARNI at the same time?
Yeah, it's a great question. And obviously we need to personalize that dose for the patient's circumstance. The recommended starting dose for de novo use would be the 24-26 twice daily, but in an individual patient, even if you want to start lower dose, I think what we saw from the analyses of Paradigm, you were still, even if left on very low dose, better off to be on lower dose sacubitril valsartan than enalapril. And we see the benefits of these drugs, even at low dose, are a lot of that benefit, and then some additional benefit from full dose. So you're better off on lower dose of all 4 than on full dose of 1 or 2, and then the delay in introducing the 3rd or 4th. So I think this can work regardless of the patient population, regardless of race, ethnicity, given that we've seen the ubiquitous international benefits of these trials in the large multi-center trials. But personalizing the dosing and up-titration is very important.
Yep. Another question for Professor Iswaree. Based on the DAPA heart failure trial and EMPEROR-Reduce trial, these are chronic heart failure trials. So what you suggest to initiate SGLT2 inhibitors once a patient develops acute decompensated heart failure, and during admission, you start to use SGLT2 on these patients or not?
Yeah, so similar to what Dr. Fonero had stated, I tend to be a bit more aggressive in terms of initiating foundational therapy inpatient. I perhaps won't start it immediately during the phase of decompensation, but when the patient comes in, and if a heart failure hospitalization is about 5 to 6 days, they would usually be decongested by the first 1 to 2 days. And we've got the remaining 3 to 4 days to kind of up-titrate medication, see how well they tolerate it. So I do definitely introduce all doses of medicines early on, and not during acute decompensation, but once they've been decongested in the first 1 to 2 days.
So before discharge? Before discharge,
yes. And I think hospital is an excellent time at our disposal to see how well patients tolerate it, because a lot of them, this is de novo initiation of all 4 therapies, and they may complain of side effects. And if they're able to tolerate these 4 medicines for a short period of time, for that one week that they're with us, it's unlikely for them to complain of new side effects when they're discharged and reviewed at follow-up, I feel.
Thank you, Dr. Balakrishnan. I have a question. What about people with chronic infections like diabetic foot and starting SGLT2 inhibitors? Because that's a real world challenge. I've already seen yeast infections in many of my patients starting SGLT2, which is probably under, I don't know. I mean, this is anecdotal, of course, compared to trials. What are your thoughts, of accompanying infections?
Yeah, no. So it also it's real world data versus trial data, isn't it? And I find a lot of these patients who actually develop foot infections are patients who actually have pre-existing diabetes and peripheral vascular disease. So kind of depriving them of SGLT2, they have had foot infections independent of or these genital infections independent of even before initiating SGLT2 inhibitors. So I usually don't deprive them of SGLT2 therapy because of the known benefits. Perhaps what I would do is I would have a discussion with them, tell them these are known potential side effects. We'll keep an eye on it. And if you're not able to tolerate it, we could always stop it in the long run.
Thank you.
Thank you.
It's interesting. I'm covering the hospital and I had a patient with just one kidney. And I was wondering whether I should give the full dose SGLT2 or should I give half the dose of SGLT2? I know there's no data, but these are real life challenges,
Absolutely.
I mean, if we think of the mechanisms of benefit, right, that promote such great renal protection as well as cardiac and vascular protection, we're still learning what those mechanisms may be. Certainly early on, people were concerned and lower GFR may not work because you saw less glucose lowering effects. But of course, we've seen benefits irrespective of the GFR all the way down to 20, 25. So
25, yeah.
we'd still want to get full dose.
I'm hoping that we can use it in people with even less than 15, We need data, of course,
Yeah. But these mega trial, they enroll patients with eGFR mostly above 30. So if you want to go down to 30 or below, we need more data to see whether that's true or not. Yeah. Okay, I think we are a little behind our schedule, right? Yeah.
Yeah.
So
Terrific talk. Yeah.
Yeah. So Dr. Baliga, do you agree we have to close the session?
Yeah, we'll close the session. Yeah.
Yeah, we'd like to thank all the speakers to attend this very interesting and inspiring lectures of SGLT2 and late pivotal trials on heart failure, including ARNI as well. Thank you.
Thank you all.
Thank you. Terrific talks, Dr. Balakrishnan, Dr. Fonero. I'd like to thank Dr. Ichipora and Dr. Hou for inviting me to join this session. Bye-bye.
Thanks so much.
Bye-bye.
Take care.